Dr. Ismail. Dr. Ismail have been giving lectures since long time, and he is have a very wide reputation.
Thank you. Assalamu alaikum. Thank you,
عليكم
Dr. Mahmoud.
السلام ورحمة الله وبركاته. Dr. Ismail, and mashallah, he have been recognized by many forums, many. He have even his giving the lectures for free long time ago, and he mashallah have much contributors from everywhere. They getting much benefits from his lectures, and Allah يتقبل منه. He is giving today about ultrasound, emergency ultrasound, and again, this is a very important lecture for the FRCR, especially, and for the training itself, even in the practice. So be careful to attend this one with all your mind. Hope inshallah very nice. If anyone want to have any question, just submit. We will give like last 5 minutes for questions. تفضل Dr. Ismail. Go ahead.
Okay.
Thank you.
Okay. Welcome. Assalamu alaikum. Inshallah, in the next few minutes, I will discuss some common and some uncommon cases related to ER. Let's start by general rule. We learned this rule from our professor, Dr. Mamdouh Mahfouz. Radiologist is not imager, is not a radiographer. He is a clinician. He must correlate clinical data, laboratory data, and imaging findings. Please do not work alone. Okay, let's start the first few cases about abdominal emergency. Right iliac fossa pain. This is easy case and very common. Acute, not just right iliac fossa, peri-umbilical pain. Diffuse abdominal pain. In children or middle age, suspect appendicitis. This is very easy and direct. Please, my friends, I want some interaction. What is the clue in this case? It's very easy. It's not the appendix. What is the clue? Anyone can share the answer? Yes, fat. This bright fat, echogenic fat. Echogenic fat is the most important sign in sonography in emergencies. Echogenic fat with an appendix in its epicenter, it means appendicitis. Someone asking, maybe colitis? No. Maybe diverticulitis? No. What is the structure in the center? In the center. Okay, I will comment on the size. No. Echogenic fat is more important than the size because some appendices may be filled with fecal matter. It will be enlarged. It show lymphoid hyperplasia. It will be enlarged. But echogenic fat means inflammation. Appendix thickened within the center of echogenic fat. This is a direct case. It's appendicitis. It's very common. The correlation with CT, this is a picture from Radiopedia. This smudging fat, dirty fat, streaky fat, whatever the term used in CT scan around the appendix, we have here echogenic fat. This is the first case and it's direct. Okay, so ultrasound will be enough? Yes, and it's a surgical case. Young girl with acute pelvic pain. In young girls or middle-aged female, any abdominal pain or any pelvic pain, okay, appendicitis will be on top of my list, yes, and acute gynecological conditions. What are the surgical conditions in gynecology? Torsion, and rupture hemorrhagic cyst. If unknown last semester period, okay, rupture ectopic also will be in the differential. Let's start about this young girl. This is the urinary bladder, and this is cystic structure. Cystic structure with turbid content superior to the urinary bladder, maybe hemorrhagic cyst, yes. Maybe dermoid cyst, yes, in the differential. What about the appendix? Please look at the right iliac fossa. Okay, I started scanning the right side of the abdomen. This is bowel loop, EBS. It's reactive to many conditions in the abdomen. Use the linear transducer. Look for echogenic fat. Again, echogenic fat inferior to the liver, paralleling the ascending colon down to the ileocecal valve. Echogenic fat is still seen. I am close to the source of abnormality. Now I see the terminal, the cecum and terminal aim, and again appendix. So this is called satisfaction syndrome. Sometimes you catch a major pathology. Alhamdulillah, I'm happy. This young girl has adnexal cyst. Okay, what is the next step? MRI after 1 or 2 days. No. Complete the differential diagnosis. Each case has abdominal pain. Please rule out appendicitis. Look for echogenic fat. Of course, this is a blind endotubular structure with thickened gut signature is preserved. Okay, it's appendicitis. Continue with this appendix. Yes, it go down till this cystic structure. Actually, this cystic structure is surrounded by echogenic fat and containing mesenteric lymph nodes. It was an appendiceal abscess. It's not adnexal cyst. It's complicated appendix by perforation. Okay, where is the perforation? Usually it is pinpoint in size. You can't detect the perforation point in most of the cases. But appendicitis and cyst related, suspect appendiceal abscess. Okay, what is the next step? Is it surgical? No. Appendiceal abscess usually drained by or treated by surgical drainage and elective appendectomy after a few weeks. Okay, so drainage direct? No, I prefer after CT scan. Why CT scan? To determine the point you can drain and avoid major structure, avoid perforating bowel loop in front of this abscess, and so on, and determine the extent of this abscess as well. So in non-complicated appendicitis, ultrasound will be enough. In complicated appendicitis, ask for contrast-enhanced CT scan. Okay. What about pain on the other side? Left iliac fossa pain. I will suspect colitis. Most clinicians suspecting colitis rather than diverticulitis. But you are radiologist. You are the eye of medicine. Okay. After ruling out all abdominal organs, it's okay. Now there is a thick mural thickening of a bowel loop present in the suprapubic area and left iliac fossa with echogenic fat. Oh, this is the center of inflammation. Just a small note about the wall of the gut. This hypoechoic layer is a musculosa, and this echogenic layer is a submucosa. When the submucosa is thick, it means inflammation. Just inflammation, maybe colitis, maybe diverticulitis. But if associated with thick hypoechoic layer musculosa, usually it's diverticulitis. Look for a diverticulum. Till now, this is colitis because I cannot see a diverticulum. Thick bowel loop associated with echogenic fat, it's colitis, maybe infectious, maybe ulcerative if repeated, okay, and if it continues till the rectum. But after careful research, I see echogenic structure with posterior shadowing outside the lumen. This is fecolith within a diverticulum. This is a start point of the inflammation. And as you see, the echogenic fat surrounding this structure. So this fecolith in the center of echogenic fat. It's a diverticulitis. Okay, the next step, rule out any abscess formation. Any abscess formation in the abdomen require further imaging like CT scan. If not complicated, ultrasound may be enough. If you are not sure about complications, ask for contrast-enhanced CT scan. Looking for what? Assess the vessels for any thrombosis of the mesenteric veins, and look deeper for any abscess formation. Okay, another case, acute pelvic pain. Also, yes, in the center of the pain, a bowel loop with very thick hypoechoic layer. This is the musculosa. It means this is most likely a diverticulitis. There is echogenic fat around, yes. And here is the echogenic fat using another machine setting. Okay, this is TS. Where is this part? Actually, it's a diverticulum, but I cannot see the feculith. Maybe already released after some inflammation. Okay, another image from this patient. The patient has a multiple diverticular outpouching. Not all of them complicated. Just one will be responsible for this inflammation after being occluded. So I'm tracing where is the echogenic fat. It will guide you to the center of inflammation. After checking this bowel loop, I see fluid collection here and separate fluid collection here. If collection is around the affected loop, it's okay, maybe reactive. But if the collection is away from this loop, this is early peri-appendiceal or peri-diverticular abscess formation. Stop, ask for contrast-enhanced CT scan. Rule out any complications. I'm not looking for diverticulosis. I can see already with ultrasound. This is diverticulosis. And also diverticulitis. Okay, I see. But the extent of abscess, the state of the vessels, any other complications, better to be assessed using CT scan. In the practice, ultrasound will be a good starting imaging tool. CT scan will be supportive tool, will be a tool for complications. Usually in the exam setting, you will face a CT scan directly. Maybe the case acute abdominal pain, maybe a case of bleeding. The examiner will mention just some rectal bleeding. You will form a differential before going to the case. Oh, rectal bleeding and you want a CT scan, maybe complicated diverticulitis, maybe colon cancer, maybe angiodysplasia, and so on. Look for these pathologies and rule out one by another. Okay, we talked about right iliac fossa pain, left iliac fossa pain. Now, diffuse pelvic pain, and especially in girls, in young girls, in young adult female. What else you are looking for other than appendicitis, gynecological problems? On top of the list, ovarian torsion. Why? Because it's a high emergency. The patient should go to operating room within 2 or 3 hours, not at night, not after one day. No, just within 2 hours. So it's a high emergency. This is a 9-year-old girl, acute pelvic pain. The clinician, usually ER physician or general surgeon, please rule out appendicitis. Do you think in any gynecological causes? No, she is younger. Okay. This case from Radiopedia. I ruled out appendix by looking at the right iliac fossa. Now I'm looking at the adnexa ovaries. This right ovary is fine. Okay. What about the left ovary? Whoa, this structure is the left ovary? Yes. It is not the uterus. The uterus here will be very small because this young girl, but maybe in pelvic mass. No, it contains some peripherally displaced follicles. This is the left ovary. Why? It's very large because it is torsid. No vascularity at all after using flow sensitive measures. What are the flow sensitive measures? Reduce the velocity scale, reduce the PRF, and increase the color gain. No color inside at all. This is the second sign. Okay, what is the first sign? Enlargement. Enlargement. Just to compare, this is the size of ovary in this age. So enlargement of the ovary is the most sensitive sign to diagnose torsion. This is a direct surgical case. Honestly, no need for complementary MRI or CT. Go to operating room. It's a case of ovarian torsion. Okay, but if the enlargement was not definitive, was not conclusive, and you are still suspecting discrepancy in size, okay, go for MRI, not CT scan. Okay, not CT scan in this age group, and not CT scan for ovarian torsion, just MRI. MRI in T2 weighted images or edema pattern is a good sign. If you see low signal intensities affecting larger area of the stroma, this is a bad sign. It may be hemorrhagic infarctions. And also comment on the post-contrast study if there is preserved contrast enhancement of the stroma or no. It denotes the viability. So the first sign of ovarian torsion, especially in young girls, enlargement of the ovary. Slightly older girl, 14 years old, so it's menstruating, acute pelvic pain, appendicitis, or just a hemorrhagic cyst. Okay. Whoa. After starting the abdominal ultrasound, this is fluid collection in Morrison pouch. Something has ruptured. Maybe appendix. Yes. Maybe cyst. Look down. I see the uterus with thick endometrium, homogeneous, hyperechoic. It denotes luteal phase. Luteal phase, so I'm expecting corpus luteum. What about this structure? Okay, give me a closer look. Yes, it's a hemorrhagic. Fishnet appearance with some debris. It's a hemorrhagic cyst and maybe ruptured. That's it? Hemorrhagic cyst and rupture? No, it is abnormally located. What is the location? The ovary should be on one side, not superior to the uterus, not posterior, not anterior. Any abnormal location, especially in midline location, it means torsion. This cyst has hemorrhage, rapid enlargement, and torsion. Another case from Radiopedia, abnormal location, posterior to the uterus, enlargement. But this case, done CT. Maybe acute pelvic pain, I cannot see anything by ultrasound, or no sonographer available, so went to CT directly. I don't know what is this mess. Look here, peripheral located follicles. And oh, the stroma is not properly enhancement. There is poor enhancement. This is a bad sign. But I prefer, if you are in doubt, look for or ask for MRI, not CT scan. Okay. So this is a hemorrhagic cyst complicated by ovarian torsion. Torsion may occur without any cyst or mass, depend on enlargement. It may occur with a cyst or mass, depend on abnormal location. Okay, the last case, this case, I think from 3 days ago, 9-year-old girl vomiting for 3 days. Vomiting for 3 days, maybe gastroenteritis. Yes. Maybe appendicitis. Yes. Okay. This is a urinary bladder and this small uterus. Okay. Consistent with the patient age. What about this structure? Maybe bowel. For the first look, yes, maybe bowel. On TS view transverse section, this is the left ovary. I cannot see the right ovary, but this structure is constant. And no peristalsis, maybe a mass, maybe a cyst in the right ovary. Use another transducer, high resolution. Okay, I use the linear transducer. This is the left ovary. What about? Oh, this is the right ovary, and it contains peripheral displaced follicles with this central part. What is this? Oh, echogenic lines parallel to each other. It means dermoid mesh. This is a dermoid cyst in the right ovary. Okay, why the patient has vomiting? Why the patient has pain? Because it's torsid. How to tell? There is echogenic fat around. Echogenic fat again means edema. And another sign. What is this structure on the left side? I mentioned this is the right ovary containing dermoid. Dermoid mesh. What is this structure on the left side? It has incomplete septi and the debris inside. Actually, it was the fallopian tube. Torsid fallopian tube, torsid ovary. There is a complete tubo-ovarian torsion. In torsion, the ovary may be torsid alone. The tube may be torsid alone, but this is uncommon condition, or tubo-ovarian torsion. Another case from Radiopedia, it contains a dermoid in abnormal location anterior to the uterus. It's ovarian torsion. So remember, ovarian torsion may be presented with severe abdominal pain, with vomiting or constitutional symptoms, or pain on and off, intermittent pain. Any girl non-menstruating or any young female, please, with acute abdominal pain, look out for torsion. Okay, another group of emergencies, diffuse abdominal pain, especially upper abdominal pain. Maybe gastritis, yes. Maybe cholecystitis, yes. Okay, rule out other conditions. Here, diffuse abdominal pain, the clinician has no differential in his mind because the pain is diffuse around the umbilicus, but it's mild and for 2 or 3 days. Is it look like appendicitis? No. Okay. I checked all organs free. Now, the area of the pain, just to the left, and it has a linear distribution. I see at the area of the pain a vessel in the center of the pain, and echogenic fat around this vessel. It's mesenteric vessels, superior mesenteric vessels, and echogenic fat around. You see this hypoechoic is the normal visceral fat. This hypoechoic area, these areas, normal visceral fat, but this area is echogenic fat. It means the inflammation. What in the center? Mesenteric vessels. Check patency, please, because it may be mesenteric panniculitis secondary to mesenteric vascular thrombosis, or mesenteric panniculitis complicated by vascular thrombosis also. So I want to check the patency of mesenteric vessels. Yes, this is a similar case from CT scan, an area of smudging fat, like here the echogenic fat with patent vessels inside. So this is unexpected cause, but radiologist only can diagnose. You will rule out appendicitis and diverticulitis and colitis. Okay, this echogenic fat, what in the center? Echogenic fat is a good guidance. It's our best friend. Okay, all the patients with abdominal pain, loin pain, the clinician suspecting stones. But remember, elderly patients, be very careful. Take care. Why? Maybe just colitis or stones, or something very dangerous, like this case. Kidneys in this case were very good, but this case by my friend Dr. Ahmed Noom, thanks for sharing. The abdominal aorta contains abnormal echogenic structure. Wow, this echogenic structure inside dilated abdominal aorta, maybe ectatic. Yes, it's aortic dissection. Why the patient has loin pain? Because, yes, this intimal flap with a false lumen already extended to one of the renal veins. This is a similar case from CT radiopedia. Okay, yes, this aortic dissection and complicated by renal infarction. So maybe the cause of renal pain is the infarction secondary to arterial thrombosis. Some cases, infarction secondary to even venous thrombosis, enlargement secondary to venous thrombosis. So in old age, please check the vessels, check the aorta, IVC, mesenteric vessels, may be the cause of the pain. Okay, so in old age, please check the aorta. Rule out aortic dissection, rule out aortic aneurysm and rupture, rule out this condition also. Old patient with severe abdominal pain and distension. The clinician suspecting IO. Why? Because the patient has maybe cholecystectomy or appendectomy 20 years ago. So maybe IO. Okay. After I checked the abdominal viscera, I see the gallbladder has stones. Okay, and the thick wall and associated with fluid around. Alhamdulillah, it's cholecystitis. Are you sure? Yes, why not? There is echogenic fat also. Echogenic fat is uncommon feature of cholecystitis. And also, the lumen is not distended. In acute cholecystitis, it's characterized by a massive or enlargement of the lumen due to obstruction. Also put a Doppler, no hyperemia. So something else. This calcular gallbladder may be incidental finding. Please trace this echogenic fat. Follow this echogenic fat. Okay, I traced this echogenic fat across the epigastrium, across the midline. The echogenic fat is still here. And what is this? I don't know. There is fluid field structure, and this is the area of the pancreas. Go up, go down. I need to see the pancreas more clear. Yes, this is the pancreas, normal pancreatic tissue, abnormal pancreatic tissue. This is hypoechoic, irregular surface related to the echogenic fat and the fluid structure. What is the possibility now with this severe abdominal pain and tenderness and rigidity? It's pancreatitis. After careful looking up at this area, okay, the pancreas looks very heterogeneous, associated with this cystic structure, maybe pseudo cyst and echogenic fat, and complicated by, wow, this is a portal vein. It's complicated by thrombosis of portal vein and pseudocyst formation. The patient has repeated attacks of this pain, most likely for long-standing. So take history. This case is direct indication for contrast-enhanced CT. To confirm the diagnosis, no, I'm sure from ultrasound, but to look for complications like thrombosis, like necrosis and abscess formation, and to guide the next step of management. So please, in diffuse abdominal pain, especially in elderly, rule out the life-threatening conditions. If you are not sure about a single diagnosis, trace the echogenic fat. Look for the echogenic fat and trace it. Okay, I will talk now about some limb emergencies, not just abdominal emergencies. Okay, I'll talk about swelling and pain. The patient has acute left lower limb swelling. Okay, the clinician, please rule out DVT. Okay, common femoral vein and the saphenofemoral junction with the tributaries all are thrombosed. Alhamdulillah. I'm sure of this diagnosis. It's DVT. With acute or no acute. Why? Because it's expanded and echogenic fat. Again, echogenic fat, it doesn't mean inflammation. It means edema, congestion, or inflammation. But here in this case, it's edema. So echogenic fat here around the thrombosed vein, this is acute insult. Okay, stop here. No, I will complete the lower limb. After completing the lower limb, go up. Where is the extent? The proximal extent is much more important than the distal, because is this patient in need for IVC filter or no? So I go up. This is the right and the left common iliac arteries, aortic bifurcation. This is the right common iliac vein. Where is the left common iliac vein? Oh, it's a thrombosed, and here it's compressed. So it's extensive thrombosis involving the whole left lower limb and external iliac vein and common iliac vein up to the bifurcation. This is a nutcracker, I'm sorry, this is a May-Turner syndrome complicated by extensive thrombosis. You already diagnosed DVT and the cause of DVT. Another case, right lower limb swelling. It is not May-Turner, the clinician suspecting DVT. Okay, yes, I see thrombosed veins, and by comparison, the right common femoral vein thrombosed as compared to the left. Okay, what else? Go up the proximal extent. Okay, I look up now. The external iliac artery is seen, and the vein is thrombosed. Okay, please look carefully. Any possible cause of this DVT? Wow, what is this? It's a huge pelvic mass, lying on the iliac bone, involving iliopsoas muscle. Maybe a neoplastic process, yes, because it's echogenic and hypoechoic with separable maybe lymph nodes. Okay, so it's a tumor causing this DVT. Now, stop, please. Go for contrast enhanced CT. Refer the case to oncology. This is not just a vascular case, it's oncologic case complicated by DVT. So if you go up, you may detect the cause of DVT. It's part of our rule. Okay, what else? Lower limb swelling, query DVT. Lower limb veins were very good. Terminate the scan? No, the patient is complaining. Look for mimics. What may simulate DVT? Baker cyst, hematoma, like this patient has weakness in the lower limb. So the physiotherapy caused hematoma in the adductor longus muscle, then swelling on the lower limb, DVT-like symptoms. But in hematoma, the patient needs the reverse treatment. Take care, because if you mentioned maybe DVT, I'm not sure, the patient will take thrombolytic therapy, the hematoma will expand, and the patient may go in compartment syndrome. So take care. After ruling out DVT, check for the possible cause of edema. It may be lymph node, it may be cellulitis, it may be uncommon cause like this: echogenic nodules and palpable nodules of acute onset, 2 or 3 days. In a diabetic patient, if post-traumatic, maybe fat necrosis. If diffuse, maybe cellulitis. In diabetic and palpable, localized, it may be nodular pancreatitis. All these are benign mimics of DVT. Another clinical scenario or emergent scenario is the ischemia-like. Pain in the lower limb or upper limb. Maybe ischemia. Yes. Okay. So the clinician, please rule out ischemia. After looking at this case, the common femoral with patent common femoral artery. Now superficial femoral artery completely occluded. Deep femoral artery was patent. Oh, this is the cause of ischemia. No. Why no? Because maybe this finding is a chronic. As by knowledge, superficial femoral artery is the most commonly occluded artery in atherosclerosis. So what's important to judge the ischemia, is it critical or no, is the distal flow. Look at the anterior tibial and posterior tibial at the ankle level and assess the vascularity. If below 25 centimeter per second, it's a critical limb ischemia, and this patient in need for vascular intervention, with or without complete occlusion of the proximal vessels. So this case has a complete occlusion and the critical limb ischemia, needs emergency vascular emergency. What about this case? Upper limb pain. Okay. Wow, this is a brachial artery, complete occlusion of the bifurcation. If the bifurcation is involved, usually think in embolic cause, not atherosclerotic cause. Embolic cause, sometimes the collateral open within 6 hours. So is it emergency or no? Look at the distal flow. Now the distal flow, mashallah, above 40 in the distal ulnar and the distal radial, it's good. It means the collateral already opened very rapidly. It occurs in clinical practice. But if these vessels are totally occluded or poor collateral, again, it's a vascular emergency. So in cases of pain, okay, most of clinicians suspect ischemia, but you are the eye of medicine, not just ischemia, maybe the cause of pain, other causes, like this case. Okay, upper limb pain, I checked all vessels, accepted, normal waveform, normal velocities, but the patient has some skin changes. Okay, What else you can do? I complete the study by dynamic. Just elevate the upper limb, the head look to the other side. I want to rule out thoracic outlet syndrome. Compression on the vessels, positional. Okay, this is the subclavian artery. After elevation, velocity is mildly increased. Okay, and lumen mildly narrowed. Can it explain the symptoms? No, it doesn't explain the symptoms because the affection is not significant, but the patient has some skin changes. I need to check out other possible causes like venous compression. The same patient has this subclavian vein, and this is a costoclavicular groove. It has a compression at rest. At rest, there is ileation. This vein has stenosis, maybe central venous catheter before, or something like this, maybe cervical rib, whatever. There is compression. After elevation, what is this artifact? This artifact is called color Berwick artifact. And the velocities double? No, triple. This is significant. Although this case came for arterial Doppler and static, not dynamic, but after few steps, complementary steps, the patient in need for vascular intervention to relieve the pressure on the veins, not arteries. So please think broadly. Pain is not related to ischemia only. It may be related to venous hypertension. It may be related to other causes like this case. Pain in upper limb, especially the thumb and index fingers. Okay, arterial system was good, but what is this? Whoa, the median nerve is very thick. Okay, this number should be 9 or 10, not 31. And after comparison with the opposite side, this is a pathological one, and this is a normal. Okay, fascicular pattern is preserved, here is lost, and here was waist sign. Vascularity is seen inside the nerve. What is the normal pattern? No vascularity inside the nerve. I should never see any vascularity inside the nerve. Any vascularity inside the nerve, it means neuropathy, even if normal size. But actually, it's enlarged and lost the fascicular pattern, and there is waist sign. Just the complementary nerve ultrasound, the case is solved. Problem is solved. So radiologists need to have a broader mind, more differential diagnosis. Okay, I have 5 minutes. The last 2 or 3 cases related to gynecology, and also the same way of thinking. The patient has bleeding. It's an emergency. 60 years old. Okay, think of endometrial pathology. Okay, the endometrial mildly thickened. What if I told you 5 millimeter? 5 is accepted. Okay, but 7 just mildly thickened. Okay, you can terminate the case? No. Go out under visualization. See the cervix. Don't say one diagnosis is enough. See the cervix, please. Look at the cervix. I think the cervix is expanded. Wow, this is, I don't remember the sign. Any one of you? What is this sign called? Large vessel seen only with Doppler supplying this mass. Okay, I think, anyone knows this sign? It's diagnostic. Okay, vascular, yes. Single vessel sign. It means a large polyp, maybe arising from the endometrium and pedunculated. This lesion easily missed if you didn't check up the cervix while withdrawing the transducer. Another case, 21, with acute pelvic pain. Suspected hemorrhagic cyst. Okay, this is the uterus, and both ovaries are good. So end the exam? No. Check for the cause. After asking the patient, what is the site of pain? Okay, the right side. Wow, what is this? Blind-ended tubular structure seen adjacent to the right ovary. Actually, it is the appendix, pelvic appendicitis. Complementary abdominal ultrasound revealed, yes, thickened terminal ileum and cecum. And the origin of appendix is the only part seen, because the rest of the appendix seen in transvaginal ultrasound. This is a pelvic appendicitis. Although the gynecologist sends the case to you, but you will re-guide the case to general surgeon. I think this is the last case, 50 years old, pelvic pain, perineal pain, severe pain and tenderness, even with defecation. The clinician, gynecologist, after checking the vagina, suspecting maybe complicated cyst in the posterior vaginal wall, Bartholin cyst, Gartner cyst. Okay, uterus looks fine. While I withdraw the transducer at the vaginal wall, I notice some collection, maybe vaginal wall abscess, maybe. I withdraw the transducer and looked at the perineum. Okay, this is the anal canal, and the collection seen during vaginal ultrasound is adjacent to the anal sphincter. Actually, it destroyed part of the sphincter and causing maybe a fistula formation. It's a perianal fistula and perianal abscess diagnosed by you. You re-guided also this case. Instead of gynecology, now you will go to pelvic floor or general surgery or GI surgery to drain and reconstruct this area, not just a drainage. The next step, not just surgery, but MR fistulogram. You re-guided the case completely. So the radiologist should know the emergency conditions and the related mimics, the differential diagnosis also. As in gynecology, bleeding, withdraw the transducer while visualization. You may detect a polyp, whether endometrial, whether cervical. You may detect a pelvic congestion or hydrosalpinx. You may detect in case of pelvic pain in gynecology, incidental gastrointestinal finding like appendicitis or perianal abscess, and so on. Remember, radiology is the eye of medicine, and radiologist is a great doctor. Thank you. Thank you, Yavuz. Thank you.
Thank you, so Dr. Ismail, for this beautiful and nice presentation. Very impressive.
Thank you,
Any questions for Dr. Ismail?